Today we are going to discuss about retinoblastoma. So what do you mean by the term? Retino means retinal, blast means immature cells, oma means tumor. So it is the malignancy of neural cells of retina. Okay. This may be unilateral or bilateral. First most common malignant intraocular tumor is uveal melanoma. After that it is retinoblastoma. Okay, so you should ask demographic details like age more common in infants. Okay, so like 1 to 3 years, like that. So no, males and females both are equal in getting this retinoblastoma. Unilateral is most common than bilateral. Genetics RB gene, which is present in the long arm of the chromosome 13q14 band, which get mutated in retinoblastoma. So according to Knutson's two-hit hypothesis, which we had learned earlier in patho, so in this we have 2 hits to get retinoblastoma, as told by Knutson. So first and second, so most cases will be non-heritable for 60% and heritable is 40%. So heritable means half of the alleles of RB gene before fertilization, means one of the two might get mutated. So leads to retinoblastoma. 10% this will occur and 30% is sporadic cases. So 10% from defected gene from the defected allele from the parent. Okay, 30% is sporadic, and another one is post zygotic phase. The second allele may get mutated and bilateral tumor formation may occur, and trilateral retinoblastoma along with pinealoblastoma may also occur. Okay, this is autosomal dominant, so 50% of offsprings may have chances to get the retinoblastoma. So from the defected allele from the parents. So next, non-heritable is 60%. After fertilization, some retinal cell it will occur. It is unifocal and unilateral tumors are mostly, and this can't be passed through the hereditary route to offsprings. Coming to pathology, is tumor of the immature retinal cells. Okay, they appear as small round blue cell tumor in histopath. So histopathology, small round cells with large nuclei, because these are immature, no. So the nuclei will be large because high proliferation chances will be there. So these cells will be similar to the neural layer of the retina and highly undifferentiated. This tumor may be highly undifferentiated or well differentiated. So coming to the microscopic feature, we will see Flexner, Winter, Steiner rosettes. Means they will be arranged as rosettes. Okay, with the well defined lumen will be present, center clear, and surrounding will be like rose petals, rosettes, and Hoffner right rosettes. These will be present, and it don't have that central lumen. Okay, lumen part, it is covered, there is no central clear lumen there. And florets will be bunches of differentiated tumor, they appear as bouquet of flowers. So there may be pseudo rosettes with vascularization also will be seen. Other features will be necrosis and calcification. Coming to clinical features, one is quiescent stage, asymptomatic stage, and we may find leukocoria will see yellowish white pupillary reflex, and the eye appears as a cat's eye. Okay, and squint will be seen convergent, means the eyes will be medial. Okay, they will appear as medial. This is medial squint, and nystagmus in bilateral cases. Defective vision will be seen in 3 to 5 years of age. Coming to ophthalmic features of intraocular retinoblastoma, three signs will be endophytic retinoblastoma, exophytic retinoblastoma, and mixed endophytic and exophytic. Okay. So first, after that we will see remaining body. Diffuse infiltrating tumor also will be there in the first. Okay, in that endophytic means inward, the tumor will growing inward. Okay, and we will see neovascularization and all that. Okay, and exophytic means it is growing outward. Okay, and if it is growing outward, there may be high chance of separation from the vascular layer, right? Vascular layer is choroid, so the retina will get separated from the choroid in the exophytic. Okay, you will see similar features to that of the exudative retinal detachment and on fundoscopy examination. So mixed endophytic and exophytic, you will see both the features. Okay, growth pattern will be similar to the exudative retinal detachment. Coming to this diffuse infiltrating tumor, also we'll see the tumor will infiltrate the structures. Next one is glaucomatous stage or stage of painful red eye presentation. What will understand red eye? The patient may present with red eye and it is pain. Okay, so complaining of similar severe pain, redness, watering. It is we are not treating, so it is going into secondary glaucoma and patient are presenting with these features. And if you leave like that, you will see inflammation which is orbital cellulitis. So acute secondary glaucoma, the tumor will push the lens and iris diaphragm, okay, forward. So and clogging of the trabecular meshwork also we will see. Neovascular glaucoma will be seen. Blue ophthalmos means forward protrusion of the means bulging of the eyeball. Proptosis, forward movement of the eyeball you will see. Conjunctival condition due to increased there is inflammation, right? So increased vascular supply, so you will see condition. Hazy cornea will be seen. Intraocular pressure will be raised. Apparent intraocular inflammations you will see, like uveitis. It may be associated with pseudo hypopyon. Hypopyon means exudate, right? So you will see here pseudo hypopyon. Hyphema means decreased blood supply. So retinoblastoma masquerading as iridocyclitis. Sometimes it will be misunderstood as iridocyclitis. So orbital inflammation, preseptal or orbital cellulitis with necrotic tumors you will see. And another one is stage of this third stage is stage of extraocular retinoblastoma extension. So it will extend. So the globe will burst into the fibrotic layer, means sclera. So where it will occur near the cornea sclera junction or it may occur near the optic disc. So you will see forward pushing of the eyeball. Okay, and then this is proptosis. Then stage of distant metastasis of retinoblastoma. So it will spread. So what are the routes of spread? One is lymphatic. So through lymphatic spread. So preauricular or neighboring lymph nodes it will spread. And another one is direct extension through the optic nerve. It may even leads to the brain. It will the tumor may even go to the brain through the optic nerve. Okay. So retinoblastoma classifications, there are 5 classifications: Group A, Group B, Group C, Group D, and Group E. Group A will be small tumors, you know, less than 3 mm, and it will be confined to mostly retina. Okay, greater than 3 mm, it will be away from the fovea, and 1.5 mm away from the optic disc. Group B is large tumors greater than 3 mm. Any size tumors less than 3 mm from the fovea, it is less than 1.5 mm from the optic disc margin. So somewhat dangerous senses. Group C is still more dangerous. It has subretinal and vitreous spread also, and group D is very high risk. Okay, high risk retinoblastoma. Subretinal involvement will be there and vitreous involvement will be there. Greater than 3 mm, it's okay. And group E is very high risk. What are the features we will see in group E? It is extensive retinoblastoma. Tumor touch the lens. Neovascular glaucoma you will see. Tumor spread to the anterior vitreous space. Ciliary body, anterior segment will be involved. Diffuse infiltrating tumor. Opaque media with hemorrhage you will see. Tumor necrosis with aseptic orbital cellulitis you will see. Invasion of postlaminar optic nerve you will see. Choroid, sclera, orbit, anterior chamber, thysis bulbi. These are you will see. Involvement of all the structures you will see in group E. So group E is very high risk. So what are the differential diagnosis of leukocoria? If patient comes with the cat eye appearance, with a white yellowish thing in the eye, what you will suspect? You may suspect pseudoglioma. You should differentiate the retinoblastoma from these conditions. So pseudoglioma, congenital cataract, plastic cyclitis, choroiditis. Coloboma means there will be hole in the choroid due to the incomplete closure of the choroidal fissure. Okay, retino of prematurity, premature hyperplastic primary vitreous, persistent hyperplastic primary vitreous, and you'll see toxocara, endophthalmitis. These all you should differentiate from the retinoblastoma. So exudative retinopathy of the coats. So endophytic retinoblastoma should be differentiated from the retinal tumors in tuberous sclerosis, neurofibromatosis, astrocytoma, and patch of the exudative choroiditis. And exophytic RP should be differentiated from cold disease. So diagnosis will be, we will do ocular examination after giving atropine, after the eye undergoes mydriasis. On fundoscopic examination we will see both intraocular pressure corneal diameter will observe there, and plain eye x-rays will do. So it shows calcification, and LDH increases in the aqueous humor and lactic dehydrogenase. USG and CT MRI will do. So for further how much it is extending, is it extending to optic nerve, orbit and CNS, so we will do. And further we will do B scan USG for knowing the tumor mass, how much it is, and calcification. CT scan we should not do in case of radiation sarcoma. In case of extraocular spread we will do CT scan also, how much it is spreading like that. MRI is perfect for knowing the involvement of optic nerve and extraocular extension, but it should not be done in the intralesional calcification. So also any association in the pinealoblastoma we will find in the MRI. So what is the treatment? A conservative tumor we will do for conservative therapy, like, so we have to distract that. So distractive therapy we will do to salvage the eyeball, and multimodal therapy, chemo reduction we will do, focal therapy for consolidation, CVE regimen, carboplatin, vincristine, etoposide regimen. We will classify the patients as A, B and C. We will do that. 3 weekly 6 cycles of carboplatin we will do in day 1, vincristine 0.05 mg on day 1, etoposide 5 mg on 1 and 2, and high dose CVE regimen for group D patients. We had already talked about the groups, okay, how we divided. In group D you will see no greater than 3 mm vitreous seeds like that. So in those patients 3 weekly 6 to 12 cycles of carboplatin 28 mg on day 1, vincristine 0.25 mg day 1, etoposide 12 mg okay, day 1. So focal therapy will do cryotherapy for small tumors which are anterior to equator. Laser photocoagulation will do for small tumor which is located posterior to the equator. Thermotherapy with diode laser, a small tumor posterior to equator away from the macula will do that. So and plaque radiotherapy when we will do with iodine 125 and ruthenium 106 if the above is not working. So another one is external beam radiotherapy in case of secondary malignancy like osteosarcoma we will do, okay. So if we doing this, there is radiation uses, so you will get radiation related cataract. So enucleation will do a group E tumor, will remove all the stuff, okay. Tumor involving greater than 1/2 of the retina, optic nerve involvement if there, and we will do the enucleation in these conditions, okay. Glaucoma if there, anterior chamber involvement if it's there, will remove, okay. Eyeball contents like that we will remove, okay. So along with the maximum length of the optic nerve we will remove, okay. So if invasion there, post-op treatment we will do external beam radiotherapy 5000 rats velocity we will do that, and rats frequency will do EBR. Chemotherapy by using the CVE regimen along with cyclosporin we will do. Palliative therapy in the end care, in the last care we will do palliative therapy to protect the eye. So retinoblastoma, in what is palliative therapy means, in which case you will do means retinoblastoma with orbital extension, intracranial extension along the optic nerve. If it go to brain we will do this palliative. Distant metastasis, combination of chemo reduction and surgical debulking of the orbit exenteration and EBR we will do in that palliative therapy, okay. We will do chemo reduction, surgical debulking of the orbit exenteration and EBR. At last stage we will do exenteration of the orbit for salvage of the eye. Okay guys, thank you. I hope you understood well retinoblastoma, okay. What is a summary? Yes, retinoblastoma, the gene mutation 13 q of the chromosome, it is autosomal dominant. So sporadic will be there, and hereditary will be there. And you will see according to the tumor involvement, we will group the tumor into 5 groups, and even according to the tumor, if it is going inward or outward, we will classify it endophytic, exophytic, infiltrating, diffuse infiltrating, like that. And diagnosis, we will do fundoscopy, CT, MRI, everything we will do for knowing the extent, and we will treat with CV regimen. And cryotherapy, laser photocoagulation, thermotherapy, will do this all. That's it. Main point is retinoblastoma. You should differentiate from that leukocoria, which is a which will complain. That too should be differentiated from gliomas and remaining things. Okay, and endophytic, exophytic also we should differentiate, and we should treat the patient accordingly. That's it. Okay, if you understand retinoblastoma, it will be very nice. Okay, we had lead in patho also, the pathogens of retinoblastoma. Thank you guys. I hope you understood this topic very well. See you soon. Bye.